Clinical Reasoning in Internal Medicine. Case 3. A 65-year-old white woman is brought to the emergency room by her family for increasing confusion and lethargy over the past week. She was recently diagnosed with small cell cancer of the lung. She has not been febrile or had any other recent illnesses. She is not taking any medications. Her blood pressure is 136/82 mm Hg, heart rate 84 beats per minute, and respiratory rate 14 breaths per minute and unlabored. She is a febrile. On examination, she is an elderly-appearing woman who is difficult to arouse and reacts only to painful stimuli. She is able to move her extremities without apparent motor deficits, and her deep tendon reflexes are decreased symmetrically. The remainder of her examination is normal, with a normal jugular venous pressure and no extremity edema. You order some laboratory tests, which reveal the serum sodium level is 108 millimole per liter, potassium 3.8 millimole per liter, bicarbonate 24 milliequivalents per liter, blood urea nitrogen 5 milligrams per deciliter, and creatinine 0.5 milligrams per deciliter. Serum osmolality is 220 milliosmoles per kilogram, and urine osmolality is 400 milliosmoles per kilogram. A computed tomographic (CT) scan of the brain shows no masses or hydrocephalus. What is the most likely diagnosis? What is the next step in therapy? What are the complications of therapy? Let's see the key points of this scenario. A 65-year-old white woman with small cell lung cancer has increasing confusion and lethargy over the past week. She is a febrile and normotensive, and she has no edema or jugular venous distension. She is lethargic but is able to move her extremities without apparent motor deficits, and her deep tendon reflexes are decreased symmetrically. Her serum sodium level is 108 millimoles per liter, potassium 3.8 millimoles per liter, bicarbonate 24 milliequivalents per liter, blood urea nitrogen (BUN) 5 milligrams per deciliter, and creatinine 0.5 milligram DL. Serum osmolality is 220 milliosmoles per kilogram, and urine osmolality is 400 milliosmoles per kilogram. A CT scan of the brain shows no masses or hydrocephalus. Most likely diagnosis: coma, lethargy secondary to severe hyponatremia, which is most likely caused by a tumor-related syndrome of inappropriate secretion of antidiuretic hormone, SIADH. Next step in therapy: treat the hyponatremia with hypertonic saline. Most serious complication of this therapy: osmotic cerebral demyelination, also referred to as central pontine myelinolysis. Note the following for this patient. 1. Learn the causes of hyponatremia. 2. Understand the use of laboratory testing in the diagnosis of hyponatremia. 3. Know how to treat hyponatremia, and some of the potential complications of therapy. Considerations: this elderly woman with small cell lung cancer presents in a stupor state with hypotonic hyponatremia. She appears euvolemic, as she does not have findings suggestive of either volume overload, jugular venous distension, or peripheral edema or volume depletion. She has no focal neurologic deficits or apparent masses on CT scan of the brain suggesting cerebral metastases. The most likely cause for her mental status alteration is the hyponatremia. Considerations: the patient does not take medications. Thus, with the situation of hypotonic hyponatremia in a euvolemic state and with inappropriately concentrated urine, the most likely etiology is inappropriate antidiuretic hormone produced by the lung cancer. Therapy is guided by the severity of the hyponatremia and the symptoms. Because this individual is stuporous and the sodium level is severely decreased, hypertonic saline is required with fairly rapid partial correction. This therapy is not benign and requires monitoring in intensive care unit, ICU. Also, the target is not correction of the sodium level to normal but rather to a level of safety, such as 120 to 125 millimoles per liter.